Today, I am honored to host 4 exceptional leaders in pediatric oncology nursing, a force redefining childhood cancer care across continents. Together, they champion education, equity, and system strengthening, ensuring that nurses stand where they belong, at the very heart of clinical care, advocacy, and patient survival. Their collective impact is reshaping how the world understands and delivers childhood cancer care. Courtney Sullivan. Courtney is a global leader in pediatric oncology nursing and a key voice within SIOP nursing. She has advanced nursing education, mentorship, and evidence-based practice across diverse health systems. Her research and outreach have strengthened pediatric oncology nursing capacity in dozens of countries. Julia Challinor. Julia is an international nursing consultant whose work spans Africa, Asia, and Latin America. As co-founder of Global Power of Oncology Nursing, she champions education, recognition, and policy engagement for pediatric oncology nurses in low-middle-income countries. Through her roles in SIOP, she supports global mapping, WHO engagement, and strategic nursing initiatives. Rehana Punjwani. Rehana is a pioneering nurse leader who transformed pediatric oncology nursing in Pakistan. She founded the country's first pediatric oncology nursing education department, training hundreds of nurses. A SIOP Nursing Leadership Award laureate, she continues to advance excellence and equity for nurses in low-middle-income countries. Last but not least, Glenn Afungchwi. Glenn is a leading pediatric oncology nurse and health systems researcher in sub-Saharan Africa. His work focuses on early diagnosis, supportive care, and strengthening childhood cancer services. Through worldwide cancer and academia, he is shaping more equitable pediatric oncology systems across the region. I will start with a personal story of mine with the nurses. As you know, I am a mother of a cancer survivor. In October 1998, we transferred the care of our son Rakan to Dana Farber in the US in the middle of his treatment for ALL leukemia. On the day of the first clinic, we were met by a nurse. Later, I'm told she was called a nurse practitioner. Her name was Andy. After the usual prior checkups and answering of questions, Andy suddenly closed her file, smiled professionally, and said, "Thank you. See you next week." We froze. Trying to stay polite despite the rising panic, I asked, "But where is the oncologist that we are supposed to meet?" And calmly, Andy replied that seeing the oncologist was not on the plan that first day. I was shocked and horrified and blurted out, "But we came all the way from England. We must see the oncologist." What I didn't say, though it flashed through my mind rather shamefully now, as I recall, was that we hadn't come all the way to just see a nurse. I know what you're thinking. But it wasn't malice, it was just ignorance. Back home, nurses didn't lead clinics. Nurses were seen only as invisible helpers, and we had never witnessed such an advanced nursing role. I soon learned, of course, very quickly how wrong that assumption was. Andy knew every protocol, anticipated every side effect, and often understood Rakan better than anyone. And I understood that while doctors, yes, they designed the treatment, but it was the nurses who carried it, guided it, and protected the children through it. And within weeks, I found myself saying, "Let's ask Andy, she'll know." and I became a devoted convert to oncology nursing. So, Julia, in this personal story of mine, here I was, a 29-year-old woman, unconsciously shaped by the cultural, historical, and structural marginalization of nurses that defined that era in 1998 here. Can you please tell us a bit more about this historical systemic devaluation of nurses and the reasons that helped shape that devaluation? And while you're at it, please explain to our audience the difference between oncology nursing and versus general nursing.
Thank you so much, Princess Dina. I just want to say it's such an honor to be included in this important podcast highlighting oncology nursing. I think that your experience is not unusual. I think, unfortunately, it continues today. I believe that advanced practice nursing roles and leadership within oncology historically has not been highlighted or well understood worldwide. I think it continues today, mostly because advanced practice nursing is confined to high-income countries in general, although that's not necessarily exclusive. It's starting to come in areas like Latin America, in Asia. I'd say I actually know an advanced practice nurse in Kenya, in Africa, but it's unusual. So I think perhaps we haven't done enough community awareness raising of the power of oncology nursing within childhood cancer globally. I think too that nurses in general are seen as such a large nursing workforce that they're almost anonymized within hospitals. A nurse is a nurse is a nurse, but we know in oncology that's not true. It's too complex, it's too complicated, and we really need specialist nurses all the way from the bedside nurse who needs to be specialized to the advanced practice nursing role that you encountered in Boston. I think that this is something we're working very hard on through SIOP Nursing Network, especially, and other associations within the oncology subspecialty. But I think we have a long way to go. But thank you for highlighting your experience because it's very powerful.
Yeah, well, but if I want to unpack what you said, but also, we've inherited all of this structural devaluation, from even though the nursing workforce accounts for about 70% of the health workforce in the world, and yet, I suppose the fact that men dominated the number of physicians at that time, and like you said, people just did not want to deal with the sheer number of nurses and not give them their due. So we're not only fighting the stigma around just nursing or oncology nursing, but the status of general nursing as well. But like you said, we have to do a better job at highlighting the importance of oncology nursing to everybody to understand why is it that important. Courtney, we already mentioned about oncology nursing and why important it is, but please explain why is it important for a nurse to be empowered and to be part and parcel of multidisciplinary teams in pediatric oncology care? And how do outdated hierarchies in care actually harm children and affect survival?
Thank you, Princess Dina. Well, we know that all of the care that we provide in pediatric cancer around the world, it centers around the patient and the family. And that care is provided by a multidisciplinary care team. Traditionally and rightfully so, I will say a physician is the lead of that team, and nurse practitioners also are filling their roles as providers. Nurses are directly caring for patients and families at the bedside, psychologists, pharmacists, and the list goes on, child life specialists. We are all performing our own roles and responsibilities. I think oftentimes we look at the care team as a top-down hierarchy. As far as the physicians being the lead, well, they're the lead for identifying the care plan. They're the lead oftentimes for the treatment, navigation through the complications along with nurse practitioners. And I think that's okay for us to acknowledge. But as far as nurses, we have our own roles and responsibilities that are within our own training, within our own scope of practice. So, yes, we're part of the multidisciplinary care team. We're carrying out orders oftentimes, but we also have been trained differently than physicians. And we have our own scope of practice as far as, caring for that patient and that family that oftentimes is invisible and not recognized. And I say that for every team member that are a part of the multi-care team. So I think what's most important is for us as the multidisciplinary care team is to be educated about one another's roles, our scope of practice, so that we can actually leverage and synergize the care and optimize the care that's provided for the patient and the family without limiting or excluding expertise that should be rightfully brought to the decision-making table. So it really is each person, each role, each discipline being recognized for what they bring to the table. And I think that starts with interprofessional education. And we're moving in that direction. We all have our own discipline-specific education, which is very important for us to know our scope of practice. But then when you look at how we actually function within the care team, it's as a team in practice. So that starts with our education and training. And there's more of a push, within the United States, Qatar, other countries, where within university settings, nursing students, medical students, pharmacy students, physical therapy students are all coming together in seminars. And part of their training now is integration as a care team. I think it's essential for respect of one another's roles, for an understanding, so that then when they move into the clinical environment, we're already functioning as a well-respected team, looking to each other, a deference to expertise for what we bring to that patient and family's needs.
Well, thank you, Courtney. But what about, if you can explain a little bit more in layman terms to the audience, what happens when a nurse is not empowered? She is shy or afraid to give her opinion about perhaps a side effect that needs to be looked at, and so on. Doesn't this harm the children and affect survival?
Exactly. I think, what we're getting down to is the impact on the communication pathway. So when there is ineffective communication, when nurses or other care team members are not listened to and start to feel undervalued, there's a perception of hierarchy or a reality of hierarchy. The patient and the family ultimately is the one that suffers. And I think this is really an ethical dilemma. That is perpetuated through culture, through clinical culture, through societal value that's placed on nursing. And we have the responsibility, to change that through our multidisciplinary care teams.
Yeah, totally. And I know in Jordan, we have a lot more to do in that regard. Rehana, in many low resource settings, perhaps such as in Pakistan, nurses carry enormous responsibility with limited support. How would you describe the typical role of a pediatric oncology nurse in a low middle income country compared to a high income setting?
Thank you, Princess Dina, for this podcast. I really appreciate you. To answer your question, yes, there is a vast disparity in resources. Nurses face a lot of challenges in LMIC.
We can start, I mean, the list is endless, but I would like to highlight the first basic ratio. The first basic problem starts with the nurse-patient ratio. While we always advocate is a nurse-patient ratio should be equity-based and it should be 1:5 or minimum. But I have seen nurses in many hospitals, not just in Pakistan, but other lower middle income countries. The nurse-patient ratio exceeds till 1:40. So you can just imagine if the nurse has to take care of 40 pediatric cancer patients, how she's going to give justified care to each of the child. It's completely, useless to even imagine. It is so difficult. Then comes the other resources, like, talk about PP. I have seen hospitals where nurses do not get so many PPs to protect themselves or either give care to the patients. I've seen hospitals where nurse in charge, when leaving the hospital, counts pair of gloves and she only gives 10 pair of gloves and 10 syringes to nurses to use in bites. So, she has to make sure that, she does not use anything more than that. So with these kind of things and, talk about other resources, infusion pumps. No, we don't have infusion pumps. We don't have chemotherapy biosafety cabinet. So, it's much more wider and nurses have to do a lot. Like, if you talk about other supportive services, we do not have pharmacists in many low and middle income country hospitals. Nurses are the one who prepares chemotherapy. Then no psychologist, no social service. The nurses has to understand and, navigate all these services by herself. So it's a lot of burden, just not just nurse-patient ratio, but the scope is much more wider. So, and we expect that nurse to do a lot many things which she's not capable of because they do not have a professional trainings as such, or education and special education, because they are expected to rotate frequently. So, the challenges are endless challenges in lower middle income countries as compared to high income countries.
Yeah, that sounds a lot. I mean, it's a lot. And given that I experienced cancer care, pediatric cancer care in a high income country, I cannot imagine the nurse having to do all of these jobs. And I'm sure low paid and low appreciation on top of that. So it's a lot. We all have to change that. I think in this podcast, we have enough leaders who are working on this to change this landscape. Glenn, I'm sure you have some input on this question.
Thank you, Your Royal Highness. I do have additions, and I think Rehana has really articulated some of the challenges that are faced with the multiple roles that nurses have to play, especially in low and middle income countries. A nurse can be a nutritionist today and a psychosocial counselor tomorrow. And, the good thing about nursing is in our training, it is broad because of the tools that we learn, the theories that we learn that enable us to provide the care that we do and to advocate for the patients that we have. However, for us to do this better, we have needs that could go a long way to support these multiple roles that we find ourselves performing. One of these needs is education. We need to be properly educated. In specialist care, we're talking about oncology today. We're talking about pediatric oncology. And in pedagogy, we always like to start from what people know to what people doubt. If you think of a doctor, there's a general doctor. The doctor goes to specialize into oncology because there are things that they learn additionally that they need to provide efficient care to the oncology patient. It's the same for the nurse. The nurse has general training, but when the nurse is trained in oncology, the nurse learns new theories that are peculiar for care in oncology. The nurse learns new tools and how to apply them for the patient in oncology. And that makes the care specialized and more efficient for the patient in the oncology setting. So education should never be overlooked when it comes to nursing, and in this case, specialist education. The next thing is the tools. It is true that when resources are limited, nurses, because of the numbers that we have and our presence, our constant presence around the patient, we have to engage into other activities like nutrition, as I mentioned earlier. But what tools do we have to do this? Nurses across many sub-Saharan Africa and other low and middle income country settings are reconstituting chemotherapy, for example, in oncology care. But what protection do they have? Do they have the right personal protective equipment? Do they have a biologic safety cabinet? Do they have even equipment to transport the medications and safely and administer them safely? Very often the answer is no. But these patients are treated and the nurses make sure the patients are treated. And so there's a lot of support that needs to come with the education and the coordination to enable us to play that coordination and advocacy role, which we often have to play for our patients and family.
Thank you, Glenn. So Glenn, thank you very much. So basically you have given us, you answered the next question, which was, what urgent investments needed to enable the nurses in low middle income countries to deliver safe pediatric oncology care. And you talk about, for sure, education, because as was described earlier in the podcast, pediatric oncology nursing is more complex, than general nursing. So you have to have the knowledge and the education, like you said, to, put central lines. Central lines are probably added by the surgeons, but all the other stuff that you need to deal with regarding pediatric oncology care, especially also if you're a nurse in a bone marrow transplant department, you also have other education that you need to be trained for. So you're talking about education and, of course, to have all the equipments and all the tools needed to deliver safe pediatric oncology care, and with the idea of protecting the actual nurses. Because I remember when we first started fixing our own cancer center, when I was Director General of the King Hussein Cancer Foundation, I remember when we first started to be involved and to see, the status of our center at the time. And I remember how, nurses who were mixing up the chemos did not have the protection, nor the masks, imagine, to be able not to inhale all this toxic fumes and so on. So I hear you, Glenn. That was the case then. Of course, alhamdulillah, we progressed since then in our cancer center. But I know in many countries that is still the case. What about Glenn? You seem to know about I've heard about there's so many nurses who are working in the community and in Africa specifically, and they're utilized a lot more, and they certainly outnumber the number of oncology nurses. What do you say to that? Is that something good and a different model that Africa is following? Or what are your thoughts on this?
I think nurses who are working in community settings play a very important role for oncology as much as for other conditions, because they are at the forefront. They are the first people that the patients come in contact with. In many settings across sub-Saharan Africa and other low and middle income countries, you don't have a doctor at the very basic health center, but you have a nurse there, you have a midwife there. And those are the first people that see a child who comes with a possible sign or symptom of a cancer. So these nurses at the community are pivotal when it comes to that early diagnosis, early detection, and referral, which makes the most difference for treating cancer in a resource-limited country. Because the biggest challenge on to date remains late diagnosis and abandonment of treatment. So we've had several colleagues who have been engaged in identifying patients early and referring them to specialist centers. And they've also been engaged in the continuous follow-up to ensure that patients go back to the communities, they come back to the specialist centers for their subsequent treatments. And when they have a minor ailment, they can go to the community health facility for management. And that coordination and collaboration between the specialist center and the community health facilities really makes a difference. And the people at the center of that coordination and that collaboration are the nurses, the specialist nurse at the specialist center, and the general nurse at the community center. So it's really important to engage these community nurses. It's true they also have a lot in their plate, but they are also very willing to collaborate every time you approach them.
You are absolutely right. So they are part and parcel of the team, like you said. I mean, since, like you said, many community health centers do not have oncology nurses, they are very important players for early detection. But do they get then, I mean, is it happening that there is a lot of coordination between them and the specialist centers? Are they getting extra training of some sort? How else can we utilize them better, Glenn?
So I think you've just given excellent suggestions, because we need them to participate in this care, which we cannot do alone at the specialist center. The specialist centers, we must remember, are usually few in each country, and the patients come from homes that are very far away from the specialist centers. And it's counterproductive for the treatment and recovery of that patient to keep them at a specialist center for the duration of their treatment. They have to go home at some point, and we cannot cut the care or discontinue their care when they go home. So we need setups that provide the right education to our colleagues in the community to give this minimal levels of specialist care which is required to keep these patients in treatment and to make sure that their treatment is successful. And this is one thing which is not well developed at the moment. And there is an opportunity here. There's an opportunity because we have colleagues who have started doing like early detection training for community nurses, but we need to do more. We need to develop training packages that are targeted to the type of care that our colleagues in the community can support for children with cancer when they go back home. So I think you're absolutely right. That education is needed to fully engage them.
Thank you, Glenn. And of course, now we in the childhood cancer community, we have been very happy, to say the least, that finally 2 years ago, WHO, was it 2 years ago? I can't remember exactly, when the WHO Global Initiative for Childhood Cancer, when it was declared. We're certainly very happy that that has started. And this global initiative has acknowledged that what cannot scale up the fight against childhood cancer without oncology-trained nurses. You absolutely cannot scale it up. And as Dr. Carlos Rodriguez Galindo from St. Jude Global, one of the main leaders of this WHO Global Initiative, he said, you really cannot scale childhood cancer care without oncology-trained nurses. They are the foundation, full stop. So I will have each one of you answer the next question, but maybe we can start with Courtney first, and then we go around the screen with everybody else. Can you give us, Courtney, real-life examples about how global SIOP nursing programs made an impact in helping shift the perception of nurses from implementers to leaders and partners in care, especially in low middle income countries? and give us some real life example. What happened when nurses were invited into a policy or leadership space? What changed on the ground? Tell us what, through one model of success or case study that you witnessed personally.
Well, I would like to say within our organization, first and foremost, I'm pleased to share that a few years ago, the chair of the SIOP Nursing Network became a member of the SIOP Board of Directors. So I am the second chair of this network to be a member of the Board of Directors. And this is structural empowerment within SIOP, having a nurse leader at the highest levels within the organization. That speaks volumes, first and foremost, about how we are elevating the nursing voice and nurses within the organization to lead and to be heard and to be supported in the work that we're doing within the organization. So I think that's where it starts, having a nurse who has a seat at the table. And then I'll say, one of the projects I would like to spotlight, and my other colleagues can discuss other projects, is the SIOP Nursing Quality Improvement Scholars Program. This is led by our esteemed colleague, Dr. Marilyn Hockenberry, within the network. And this provides structured didactic education modules for nurses in both Spanish and English. It's a 4-week didactic course teaching nurses about quality improvement methodologies. And then for the next several months, they are paired with a mentor and they meet monthly to walk through the design of a quality improvement project and implementation and evaluation of that project within their units. So now those are multidisciplinary teams, which are nurse-led. So within those environments, first and foremost, we're through education and mentorship and support. We're providing, small micro grants for these sites to implement those projects. But this is really leading to advancing knowledge and quality improvement, change practices within the hospital. And it's also bringing together the multidisciplinary team within those settings to where they are all learning the same information about QI principles, and they're supporting the nurse leader in implementing this project. So I think it's a change, it's a shift, it's a culture dynamic shift to be able to say that a nurse can lead a change improvement project within the hospital, supported by their peers. So that's one exemplar.
Amazing. Rehana, can you give us an example from your end?
Yes, there are many things. I am very grateful for SIOP, for St. Jude, and for W Virtual Cancer, for Sanofi Aventis, for My Child Matters grant. And I have many examples where I've seen differences created by these grants, these opportunities. And I have seen nurses becoming leaders because of the support that these organizations has provided. For me, I can share many examples, but one example, which is one of my colleagues did a very, very special project on infection control. She developed infection control programs and she taught many, many, many nurses from the country for infection control practices. And we know that if you want to scale up the survival of children, we need to have better infection control practices. And this is one thing that nurses can lead and do. And My Child Matters provide grants, which is exceptionally well, which is, and this is one opportunity I would say that, this is the only grant nurses get, which is given to nurses to do projects which they feel very near to their hearts. So with those grants, they do projects which is very, very, very effective at the bedside care level. They do projects on infection control practices, they do projects on patient family educations. I've seen projects on community health education, nurses education for early warning signs, for early recognition of childhood cancers. So, these kind of initiatives, these kind of grants not just only provide seed money, it's not much money, but it provides autonomy to nurses, empowerment to nurses, and visibility. I think visibility is very important. When nurses are given an opportunity and they do projects which are very real to patient care and which is, which is at the end of the bedside and improves the care at the bedside level, they get visibility in other specialties, like even in physicians forum, they get seated at the table because they are doing something which is improving, and this gives them autonomy. This gives them leadership. So I think those are some things that are really really important for nurses.
And Glenn, what other examples you can give?
I've seen several examples of the Global Initiative for Child Cancer creating impact at advocacy level with regards to inclusion of nurses. In Cameroon, for example, Cameroon is a focus country of the GICC, and myself and a few other nursing colleagues have been involved in some of the planning work, in the identification of priorities that go into this to the framework of the GICC in Cameroon. And not only in Cameroon have I seen this, I had the opportunity to see this happen in other countries in Sub-Saharan Africa, like Ghana, Kenya, Zambia. I've seen nurses sitting at top tables with officials of the Ministry of Health to discuss the immediate and mid-term future of pediatric oncology at the national level. I think this is a great momentum that is building around the Global Initiative for Childhood Cancer, which must continue. And we're really hopeful that it should not only end at the level of including nurses at the level of discussions, but also it should translate into pockets of, it's fair to say, money being dedicated to address the nursing issues at national level.
Yeah. And I think Glenn, nurses are often missed in national cancer control plans. That's the thing. And I think once we keep advocating for nurses and all other healthcare professionals who play a role in fighting cancer, whether for pediatric or for adults, to become part and parcel of the national cancer control plans, there is the hope that therein, once the national cancer control plan gets a budget, so hopefully the nurses will get their budget as well. Julia, you have been involved in empowering nurses and with SIOP and the WHO Global Initiative. Can you give us an example also of, whether on baseline nursing standards or nursing and nurse specialists' role at the WHO Global Initiative and other?
Thank you. I think I can give you a good example from Latin America. I have to do a shout out to one of the biggest supporters of pediatric oncology nursing, which is Dr. Liliana Vasquez, who's with the PAHO in Washington, D.C. now, but originally was in Peru when you can believe it, GICC started in 2018. We're already in the ninth, I think it is I guess if we are like 8 years into this initiative. But Dr. Vasquez started immediately in Peru when she was there first and continues with her role at PAHO. She assembled a Peruvian nursing committee under the umbrella of the GICC, and they addressed exactly what you mentioned. They actually they began by addressing childhood cancer, oncology, nursing, scope of practice, and they published on this. It's available for free on the PAHO website. They now are tackling competencies of pediatric oncology nursing, and by bringing together a whole national cohort of pediatric oncology nursing experts and international advisors to develop these resources for nurses to, I think, be a perfect step into what you say. If nurses are not mentioned in the national cancer control plans of these countries, especially at LMIC, we can be not surprised if there's very little action taken. But it's not just the words, it's also the funding that allows the work to continue. And that, I think, is an important step. So we're really, actually, I have to also mention Glenn's work earlier, years ago, with the National Cancer Control Plan in Cameroon, by putting nurse leaders in those planning committees. And I would like the committees to please put the authorship and mention who's a nurse and what the disciplines are of the people that constructed those plans, because it helps us to advocate in other countries and show how nurse leadership inclusion in NCCP, National Cancer Control Plans, is strengthening nursing across those countries in ways that are very innovative in some cases and can be duplicated in similar settings. So thank you for that question, because I think that's core to what the GICC has been able to accomplish, and nursing comes along with that as a key component of success in improving survival and care. Even if survival is not possible, the care of those children. And that's paramount to our nursing mission.
And actually, you've kind of answered, Julia, you and Rehana, actually, because you brought the mention of grants. You kind of, I had the question to ask, what role should global donors and institutions, whether WHO, UICC, St. Jude Global, SIOP, WCC, My Child Matters, and other donor institutions who actually give out grants in elevating nurses' role in LMICs. So, Rehana, I think you answered that. It gives proof of concept, right? And this is what, Julia, that's what you have said. Proof of concept of how nurses can improve quality control, they can prevent harm, they can elevate and protect the children with cancer during their treatment and so on. But how can we make those grants become much more than they're very few and far between? Does anyone have any ideas how we can through the WHO Global Initiative perhaps to advocate for more grants to elevate the role of nurses and make use of them, especially that we know that you cannot scale up cancer care without the nurses being trained and educated and empowered. Would anyone like to chip in for that answer?
I think that's a very good thing to start addressing at this point in time for meaningful improvement in nursing considerations across our setups. If we can put a name on some of these grants, I know several organizations have done that, and if we can keep doing that, put a name as this grant being for a nurse, keep a quota of each grant initiative for nurses. And we want to see those quotas grow. We want to see nurses competing for $100,000, $1 million grants that are open to nurses to empower nurses. And mind you, nurses can also engage in multidisciplinary research, multidisciplinary implementation science projects. So it's true the doctor is the lead of the clinical team. But when it comes to research, when it comes to multidisciplinary implementation, the nurse also has the capacity to lead in many ways. And I think it also comes to, at the level of big institutions, demonstrating that equality that a nurse with a certain level of training can access a position that a doctor with a certain level of training can also access. So there shouldn't be positions, there shouldn't be ceilings for the growth of a nurse. A nurse must be able to aspire, and it must be possible for a nurse to get to the top, so long as they have the right education, not having to go back to medical school. as a nurse, you're a professional, and we grow in the profession. There must not be positions that will require a nurse to go back to medical school to acquire. And I'm not talking about a clinical position. In clinical position, the clinical nurse is a clinical nurse, the clinical physician is a clinical physician. But when it comes to research, advocacy, leadership roles, nurses get the right training and can really excel in this leadership position, and therefore they deserve the opportunity. The next thing is recognition by institutions, and bodies like the WHO can push governments and institutions to recognize the specialty of nursing in
Yes.
pediatric oncology, in oncology in
Yeah.
general.
Mm.
We have
And
countries who have been training specialist doctors for many years to treat patients with cancer, but they have never established training programs for nurses. So they recognize that they need specialist doctors, but they don't recognize that they need specialist nurses. Those are the kind of agenda that we need bodies like WHO to push.
yes, and I think what everybody or I hear from you, Glenn, is, and I think also Courtney mentioned that as well, we need systemic shifts, right? It's changes in the system. Simple example, what Courtney gave, having a seat on the board of SIOP. You mentioned having a quota in the grants, for cancer care in a low middle income country. Nursing have a part of that, a quota for that part. Making sure that nurses are on national cancer plans. These are the systemic shifts in LMICs that we need. And I think WHO and GICC, they're in a good place to push for these systemic shifts. Cultural shifts, they take time, but systemic shifts can cut that time in half. And this is, I think, what we need moving forward. Rehana, we're talking about education. Glenn has mentioned that a lot. Clearly, we know that nurses need a career path to be recognized, to be appreciated, like in any other profession. So starting with certification, why does certification in pediatric oncology nurse make such a difference in outcomes for both patients and the oncology nurse?
Yeah, thank you so much for this question. It's very near to my heart. Um, in 2009, I started a nursing education program in Pakistan because I was the nurse who was thrown into pediatric oncology nursing without any training in education. I had no mentor, no education, no books. And I learned by reading books of physicians. I did not know any resources. And at that time, I had no mentor from, the globe who I can reach out. So, I had to really make a curriculum. And this is what I thought that, if I had to learn myself, I need to create something concrete, a curriculum for others, which can help them. And I started that education. So what I learned from those 10 years of really working hard and developing those education programs is that it gives nurses a sense of confidence when dealing with these patients, which they lacked in previous years. Like, once you train these nurses, they are not really very insightful, but now they understand what is happening. What are they doing it for? What are the reasons? What not? If we talk about infection control and if we teach them, they understand what is the reason behind it. And they have this confidence to stand around and give physicians those details and tell them that, this child is doing well, this child is not doing well, this child has. And they are able to recognize the sign and symptoms, the complications of the early warning signs, chemotherapy. They can anticipate chemotherapy side effects and they can work through it. And yet, by all this, they were able to talk to parents very, very nicely because, in previous years, I've checked that, the nurses had low confidence, low self-esteem. So, they were not able to talk to physicians. They were not able to talk to parents. They were unsure of what to talk to kids. But when you give them a good education and they understand what they are doing, it's so much better. They know what they are doing. And, it improves not only the child's care, but it improves their own understanding of the disease and their own role in this special fight against cancer. So I think education is super, super, super important for them to be given. I cannot emphasize it enough.
Totally agree with that explanation. Julia, what other practical steps can institutions take to foster true team-based care where nursing voices are heard?
Thank you for this question. I have to just tag on the end of what Rehana said. I always say you can take resources away from nurses, but you can never take knowledge out of their head. So the one beauty of education, of specialized education, is the nurses are empowered by that and can be even more professional in their care, demonstrating how critical they are to the success of childhood cancer survival, which I think in low and middle income countries, we could agree starts with safety. So now I'm going to address what you just mentioned about what can we do practically to ensure the safety of children under treatment and the workplace safety for the nurses and the families too, because we work with hazardous medications. We work with very complex treatments and modalities of delivering treatment, the way we deliver treatment. And I think that one of the things that's really come out over my 30-year career of working only in low and middle income countries, I spoke to a nurse in El Salvador years ago in the 90s, and I said, what is this education? What difference has it made for you? And she said, we never understood why the children got fevers after they first got their chemos. And then when we were taught that the fevers were expected because they were going to be immunosuppressed, and they were going to be more at risk for infection, and that meant fever, we now knew to look out and to take better care and more careful care of the kids once the chemo was actually initiated, because we knew then that there was a risk of infection. Before, it was always a surprise, and they didn't know what they could do as nurses to help prevent this. It's a whole multidisciplinary team approach, but I think that's an example of how you can explain what Rehana was saying, that if you understand the pathways of infection, then you see where the nurse can intervene, and the nursing practice can help prevent that from being a risk for the child or reduce the risk. It may not be able to us to never have a child with a fever, but definitely we can reduce the risk of it. I think that also it's important, and Rehana has reminded me of this forever, nurses' roles in research in any capacity is not just to be a data collector. Nurses have a lot more to offer in research, and researching nursing practice in the US and other high-income countries is what made us more successful and having higher survival rates. And I think that if we could translate that to the physicians who really hold the controls of who gets opportunities to participate in research and grant funding, if the grant said that every project that is physician generated must have at least one nurse on the project, we would take a giant leap to seeing funding in nursing from whatever the funder is. And it would follow a model that Boston Children's initiated with their global outreach program, when they brought a physician initially, and then they brought nurses separately. Back in the early 2000s, they changed the program and they said, we want a physician and a nurse from the same team to come for the 6 weeks and do the project, because cancer care requires a nurse and a physician. And I think we could use that same model and equate it to research. And it was successful in Boston Children's, it's successful in other groups that have done that kind of multidisciplinary education, and say we want to translate that into research and grant funding, because that's the way to push it forward. Now you've got teams talking, communicating, and collaborating on the same project, and you've got nursing representation. So you're going to get a two-pronged output, an outcome and improvement.
Yeah, I mean, nurses are the front line health workers. I mean, I saw the nurse 90% of the time. I mean, it's crazy that we have to fight for what's obvious, right? But is the GICC working on this, Julia? Are they, is that one of the recommendations about research and so on, that nurses have to have a part in a project along with a physician?
I think we've seen it at the country level in some countries. I don't think we've seen it as a major push within the GICC. I mentioned Latin America, where it's definitely highlighted. I think Courtney can give a couple of examples in other regions, but I think that we could use help in highlighting the importance of nursing from within the GICC countries. All the things Glenn mentioned about where nurses could be leveraged within all programs that the GICC is now stimulating. It may be 8 years, but in many of these countries, the GICC becoming a focus country is only recent. So we can learn from the early countries that joined what worked, what didn't work, how could we do something similar, how do we adapt it for our setting, and then be even more informed for the countries that are joining now, because this is not easy. And countries with very low, especially low-income countries with limited resources, how do you exploit the resources you have and the workforce you have to improve the childhood cancer care is not obvious always, but you can learn from what other countries did, where they say, we tried that, we didn't find that as successful, but here's where we were able to make an impact. See if you can do that.
Yeah, absolutely. I really believe in not reinventing the wheel. I mean, that's exactly what we did at the King Hussein Cancer Center in Jordan. I went to St. Jude's Children's Research Hospital and the ALSAC Foundation to learn all I can from there to start our own foundation. And I know our doctors and nurses also had a lot of collaboration with St. Jude early on. Like you said, don't reinvent the wheel. Learn not only what to do, but also what not to do. So that's really helpful. Courtney, I know we're talking about challenges of pediatric oncology nurses in low middle income countries, but I'm sure high income country nurses also face some challenges. Can you tell us about those, please?
Yes, of course. Well, in high-income countries, we are seeing quite a bit of turnover in the nursing workforce. And, it's really often due to the workload, the cognitive workload that nurses are experiencing, the many things that they are coordinating between multiple disciplines. They really are the care coordinator and communicator, advocate on behalf of the patient and family, while they're also monitoring and administering their treatment regimen. So there's very high quality and high acuity levels of care that are being provided by nurses. For example, within the United States, oftentimes are the kids who come into the hospital now, are the sickest, who are requiring the most intensive monitoring, which would be equivalent to intensive care unit type monitoring in many settings. So those nurses are responsible for many different the oversight of the patient care. So, for nurses, and I think, we'll get more into this as far as compassion fatigue and burnout. But if you look at the work environment, burnout is really the output of a work environment that's not supportive for nurses. So nurses where there is not structural empowerment in place, and we see this in magnet institutions within the magnet model. Structural empowerment is one of their pillars. There's a reason for that. So having nurses, be able to improve practice if they're seeing issues within the clinical setting, to be able to have a practice committee that they can bring that to, make changes, be a part of the solution that they're seeing, system kind of failures with. So that's just one example of, the burnout that we're seeing if nurses are not able to be empowered to make changes. Then we also see with the nurse staffing, although within the United States we have the most nurses out of any country in the world, nurses are still getting burnt out. And so, it's again with that cognitive and with the complex patient workload that they have. And I think with compassion fatigue, you look at the longevity of care that we have in pediatric oncology. We really get to know our patients and families. We walk with them through this journey and we carry that load with them. It's impossible for us not to. And so it's really creating those healthy boundaries, and with our newer nurses, giving them the tools and the skills to be able to create professional boundaries, to be able to take care of themselves, but also to have that recognition within the organization to have organizational resilience. It's not only on the individual. We need to have systems in place to be able to support our nursing staff. And I know that many hospitals are working on that as well.
Mm-hmm. And I know in high income countries, you have a name for it, compassion fatigue. And I read somewhere something called moral distress as well. There, these issues are named. And yet I will ask Rehana this question. Probably in low middle income countries, you're just told to get on with it, right? Nobody's stopping to ask you or have systems in place about, burnout or compassion fatigue and whatever. Can you speak to that, Rehana?
Yes, thank you so much. Yes, worse than what you said. When I was a nurse and when patient died, our seniors used to tell us that you cannot cry, you cannot be sad because this is your job. And if you cry, what happens to others? You cannot have emotional burnout. You are not allowed to do that. You are nurses. But as far as I worked in pediatric oncology, I learned that it is important to embrace that grief because we are at the center of care. We meet children, and trust me, we build relationship with not just children, but parents so close that we feel the same kind
Possible.
of grief. And I cannot tell you those times when I was at bedside and I used to work with kids. If you ask me, I still remember their faces. I cannot take it off my head. Few survived. I need them yet now until they are all grown up with kids. I cannot break that relationship. That's not possible. So how can I made sure that I don't have that grief. And when I realized that this is wrong, when I became a leader, I made sure that this does not carry on the same way. I remember that when we had some expiry of a child, I used to make sure that all nurses used to cry and we all cried together with parents. I said, it's okay. But in LMIC, we don't have that kind of support. We don't have support groups. There's nobody who can help us get through those griefs. What we really do is we do it with each other. We find comfort in each other. And we understand that, this is a hard time for all of us. We do this with parents. I know nurses, it's sometimes considered taboo in our part of the world to cry with parents because they say that you get too emotionally attached to the parents. You're a nurse, you can't do that. But, we have to allow that. Where would our grief go? We cannot take this all burden. And this is why I see many nurses when they become mothers themselves, they don't want to work in pediatric oncology. They say that it's too hard for us. I see my child face in the children's. I cannot do that. So, we do not have the luxury like in higher income country to go to the counselor to talk about it. So we do it amongst ourselves. So I don't know where will we be after 5 years. Would we be able to even explain all the senior nurses or all the mentors or everybody about compassion fatigue? But at least we are trying, few of us who are still in the country and haven't fled, we are trying. We are trying to change the concept that it is okay to cry. We are all human beings.
And as a parent whose son did chemo for 1.5 years, and then we went through the bone marrow transplant and so on, I totally hear you. You make relationships, by the way, not only with nurses who take care of your child day in and day out, but also with other parents. And you do become connected, and you do feel sorry, or you cry and you get extremely sad when another child dies, and so on. So we're only humans after all. And it is I like the fact that you maybe don't have professional counseling, but you made these support groups, and it is maybe not the next best thing, but it's something at least to help other nurses cope, especially, by the way, for the fact that childhood cancer in high income countries, they see close to 70% survival. I mean, certainly, let me give an example for leukemia, 90% survival rate. Yet in low middle income countries, you probably get about 10% survival rate, if that. So you can imagine how many, the toll on the nurses to have to manage the grief for seeing almost 70% plus, plus, because different diseases have different, of course, cure rates, seeing 70% of their patients die. So we really need to instill systems to prevent burnout, which ultimately, like you said, it leads to nurses leaving the profession, or and not being retained at a time when we totally see a shortage of nurses. Glenn, or I think, no, Julia, this is a question for Julia, unless Glenn, you want to say something to that about the burnout and migration.
Glenn, you go ahead, because you're living it in Cameroon, yeah?
Yes.
Thank you.
Glenn, I'm sure you have a lot to say about retaining nurses, burnout, migration, and so on. Please tell us about that from your experience in Cameroon.
We'll just follow up by saying what Rehana explained is so real across several settings. But I want to give a shout out to one of my colleagues, Vera Jamshi, who, through one of the My Child Matters grants opportunities, developed a project which was about developing psychosocial support action plans with colleague nurses at different centers in Cameroon, and supporting them to implement these psychosocial support plans across 2 years. She did this across 2 years. I think those are the kind of programs that we need, and we need them to be sustained. We need the systems to adopt these programs so that it's not just a grant that when it's finished, it's gone, but it should be part of the system. I think those things, and there are methods, like you say, we don't need to reinvent the wheel. People already know how to do it, including nurses, like my colleague. But with regards to migration, I think this is one thing that hits us really hard every time. One thing which will help is recognition. We've talked about training and education, but the recognition needs to come. There are a lot of nurses in sub-Saharan Africa who are well trained in pediatric oncology. They have received several trainings, but if you offer a training tomorrow, they still take it because they have not had a stamp as specialized. So they still feel they need to get more training to be recognized. And it takes for systems to give them this recognition for them to be empowered. And when you recognize a training like this, you give somebody a responsibility that befits the level of training that they have. If they are pediatric oncology nurses, there are responsibilities that they are supposed to be able to do. We've seen cases where pediatric oncology nurses with good training are patronized for doing day-to-day things. They are congratulated for doing basic things of their profession. That's not recognition. That's patronage. The nurse should know that they are well trained and they have the responsibility, and they should take responsibility for things that go wrong in their department. That's when our nurses would be fully recognized and would feel that they have a part in this whole multidisciplinary team, which is theirs.
I know when Corona came, COVID-19, nurses became visible, right? Their courage, their sacrifice, and the system dependency on the nurses. Of course, we all knew that all along, but suddenly COVID, outed that. And people applauded for nurses, they clapped and they thanked the nurses, so on. And I know 100,000, I'm told, nurses died during Corona. Did COVID help forward the role of nurses worldwide sustainably beyond the applause at the time? Julia, can you give us an overview about that?
Sure. I think it was interesting that the year as a nurse was the same year as the COVID pandemic. And they extended it at WHO, and the International Council of Nursing extended the year of the nurse into 2021 because of that. And, the visibility that we had, people appreciated it for sure. Nurses appreciated it, but they also were somewhat resentful after a while because it was saying, we celebrate nurses and we're so grateful to nurses. And there were murals painted on walls in the United States of hospitals and other important buildings. But the minute the pandemic came under control, it's as though people completely forgot the role of the nurses. We went back exactly to where we had been before. I don't think there was sustainability. I think that Glenn's point about the official government recognition of the specialty of oncology nursing, until that happens, we're really not going to be able to make significant progress forward. And I think that if we can galvanize public opinion in the same way we did during COVID and the pandemic, and highlighting the critical role of nurses, because I think there are many people that they don't even understand that children get cancer. They don't have trouble believing that children get cancer. So when all these cancer awareness campaigns, and there's been hundreds of thousands of dollars and euros spent and other local currencies spent on cancer awareness in communities across low and middle income countries, if we add to that the critical role of nursing in those awareness activities, and that's probably on us to make a push for that, we will start to see a change in the public perception of the role of nursing in cancer care, as well as in the pandemic, because we have something we can point to. You saw how important nurses were in the pandemic. Now we're going to show you how important they are in cancer care as well. And I think that may be one strategy to moving forward to getting some priority for nursing funding, for nursing, because the public is a powerful force, just like parents. I mean, if you look what Parents and Childhood Cancer International, CCI, has been able to make changes in cancer care, and the funding for the Homes Away from Home through God Bless Foundation S, and the work you're doing, Princess Dina, as a parent advocate. I don't think there's any advocate as powerful as a parent, because we can never know, ever, the true experience of having had a child with cancer. We as healthcare providers know how it affects us, and Rehana's been eloquent in her explanation of what nurses feel like, and Courtney about the compassion fatigue and the burnout. But I think that fundamentally the parents working together with nurses would be a force that would be very difficult to stop if we were going to go out to the general public and communities and say, these are key components. We have to bring parents to the leadership positions as well as nurses to inform cancer care, to strengthen national cancer control plans, to make our country's survival statistics and care match those in other countries. We don't have secrets in the United States or high income countries in how we treat kids with cancer. We know what makes successful cancer control and cancer treatment, but it's resource heavy, it's expensive, and it's time consuming and requires what Glenn said, a very specialized workforce. If you put those components together and the GICC has outlined them, you can start to really make a difference and impact the outcome in any country, honestly, any country. We can all do better.
Yes. And the thing is that the tragedy is that we all know what should be done. It's just a matter of putting it systematically, giving it a name, putting the nurses in quotas and grants, like you said, recognizing the specialty of the nurses, and so on. It requires just certain small elements that's going to make a big difference. And, leading on from this, I want to ask each one of you, starting with Courtney, if you were sitting next to a health minister or a health leader or a policy maker and next to them at dinner, and what would you, and you have the chance to say something to them about improving and empowering the role of nurses, oncology nurses, what would you say to them, Courtney?
Thank you very much for this question. And I actually have had the opportunity to advocate with different departments of health in the past. And I go back to our publication from the nurse specialists of the Global Initiative for Childhood Cancer. The top 2 priorities is recognition of nurses, of pediatric oncology nurses as subspecialist nurses through an education pathway from their nurse training to orientation as new nurses to a certificate level training of nurses, recognizing them as specialists, whether that's through the university or an accrediting body, going on towards master's and doctoral programs. So making sure that we have that educational subspecialization pathway for nurses within the country. And then second, occupational safety with chemotherapy and other hazardous medications, making sure that the ministry is providing that procurement pathway for hospitals and treatment facilities to ensure adequate PPE for nurses and other healthcare professionals who are handling cytotoxic medications.
Thank you. Glenn, what would you say?
One thing I would say is give the nurses assignments that is commensurate to the level of specialized training that they have, and keep them in that position so that nurses are not rotated across different specialties. They should be able to practice in their specialty where they are trained and they can excel, and give them the right remuneration that will keep them in the job.
Yes.
Because we talk of brain drain, but we have so many brains that are not even solicited. So these brains are going where they are being solicited and remunerated. We need to give those assignments to people who have been trained and pay them for it.
Totally agree. Nurses are so low paid in low middle income countries and perhaps also in high income countries compared to other professions. Rehana?
Yes, thank you so much. For me, I just learned this new word and I am in love with this word because it kind of summarizes everything, which is professional parity. What I would really advocate for all the nurses for around the globe is professional parity. We deserve the same kind of respect, same kind of acknowledgement, same kind of recognition, and that comes with the salary as well. We really, really deserve the same kind of parity that other healthcare members,
Absolutely.
are entitled to, even in social or cultural status. I think, this disparity disparity between the respect a physician gets and a nurse gets, it's too high. So if we want more people to come into this profession, we need to decrease this gap.
Yeah, totally agree. And Julia, the final word from you.
I'll keep it simple. I think the power is connecting people, and that includes ministries of health and their staff. And I think if I was seated next to the Minister of Health, I would say, this global community of pediatric oncology knows how to improve care in any setting. We've done it, we've shown it, we've documented it. May I connect you to someone in another Ministry of Health in a country that has similar resources and setting and social systems as you do, to learn how it can be done and how you can improve in consideration of the resources you have at your disposal. That would be my statement.
Well done. Thank you all, esteemed guests. I appreciate you as a mother of a cancer survivor. I have seen the power of an empowered nurse on the treatment of our son and how important you are. I spent more time with nurses than with oncologists and other health professionals. And I totally value every single nurse in the world, whether oncology, pediatric nurse or not. I see you, I hear you. And that's why, by the way, one of the first things when I started my podcast, I said, I have to have a session to highlight the valuable work of the nurses. Thank you so much for all that you do. Consider me an advocate in whatever that you do. I'm happy to write letters, to speak up. I'm making myself available. Thank you so much. And I know that our audience really appreciated all your feedback and comments. And I know they also, after this podcast, if they didn't know, they now totally appreciate our pediatric nurses and all other nurses in the world. Thank you so much. Thank you.
Thank you.